Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jami'an. We are still talking about viruses causing upper and lower respiratory tract infection in a human, and within this category we have the paramyxoviruses, which belong to Paramyxoviridae. These viruses include more than one important virus for human health. Include the following medically important viruses. We have the respiratory syncytial virus and parainfluenza viruses. These are the most common important agent of respiratory infection in infant and young children. Beside that, we have the mumps and measles viruses, and these are the most common contagious disease of childhood. From animal side, actually, the Paramyxoviridae family include one of the most worldwide famous virus that causing high mortalities and economic losses among chickens, that is the Newcastle disease. It is well known that more than 75% of upper respiratory tract infection are viral in nature, and this is a fact. The WHO estimates that acute respiratory infection (ARI) are responsible for 4 million children less than 5 years deaths per year. Such infections account for 20 to 40% of children hospital admission. WHO عندها برنامج متخصص upper respiratory tract infection يسمى بالآري، وهذا البرنامج أيضا معتمد قبل وزارة الصحة العراقية. The most important properties of paramyxoviruses include: firstly, the virion is spherical, pleomorphic, 150 to 300 nanometer in diameter. The helical nucleocapsid is about 18 nanometer in diameter. The genome is single-stranded RNA, negative sense, linear, non-segmented, about 16 to 20 kilobase pair. There are 6 structural proteins. The envelope contains viral hemagglutinin and fusion glycoprotein. The replication of these viruses are in the cytoplasm, and the new virion are bud from the plasma membrane. The two most outstanding characteristics of these viruses are antigenically stable and highly infectious. And the antigenically stable actually used of this characteristic for the development of effective and efficacious vaccine. Structure and composition. The 6 structural proteins include 3 protein complexed with the RNA. These are nucleoprotein forming the helical nucleocapsid, about 18 nanometer in diameter, large polymerase protein, and phosphoprotein, which is involved in the viral polymerase activity that function in transcription of messenger RNA. And as you know, the RNA of these viruses are negative sense, so to be transcribed, it should be converted to a positive sense by polymerase enzyme. 4. Matrix protein, which underlies the viral envelope, and it is important in virion assembly. The nucleocapsid is surrounded by a lipid bilayer envelope that is studded with spikes of 2 different transmembrane proteins. Transmembrane proteins, that's the proteins or glycoproteins which trans or cross the membrane. Hemagglutinin neuraminidase protein, which is responsible for host cell attachment, and fusion protein. Actually, the fusion protein is very important, and it has many different functions. So it mediates membrane fusion and hemolysin activity. The F protein is the key factor in the infection and pathogenesis of paramyxoviruses. It mediates fusion of viral envelope with the plasma membrane of the host cell during infection, and it's also responsible for cell-to-cell fusion, which permit direct viral spread and formation of large multinucleated giant cell, or what we call it syncytia. This diagram showing primary and simple classification of Paramyxoviridae, which include two subfamilies, Paramyxoviridae and Pneumovirinae. The Paramyxoviridae include human parainfluenza virus 1 and 3 and human parainfluenza virus 2 and 4. Besides that, it include mumps, measles, Hendra, and Nipah viruses, while the Pneumovirinae include the human respiratory syncytial virus and the human metapneumovirus. Okay, we will going to talk about the viruses in the Paramyxoviridae separately, and we will start with respiratory syncytial virus, which is one of the most common virus causing upper and lower respiratory tract infection in infant and children, especially in developing countries and in our country, of course. Respiratory syncytial virus is the most important cause of lower respiratory tract illness in infants and young children. It is account for 50% of bronchiolitis and 25% of pneumonia in infants. وطبعا أهميتها تيجي من النسب العالية للlower respiratory tract infection اللي يسببها. Pathogenesis and pathology. Respiratory syncytial virus is transmitted via droplets, and the droplets are formed during sneezing and coughing of infected or diseased children, and that can be transmitted by air to surrounding healthy children. Viral replication occur initially in epithelial cells of nasopharynx. Infections of the respiratory cells occur when the two major glycoproteins or surface glycoprotein, hemagglutinin and F glycoprotein, bind to the cell receptor CX3CR1 and mediate entry inside the cell by fusion. It may spread to lower respiratory tract by secretions. Viremia has not been detected. That say the virus does not reach the bloodstream. The incubation period is 4 to 5 days. Virus shedding may persist for 1 to 3 weeks. Patients with impaired cell-mediated immunity may become persistently infected and shed the virus for longer period, for months. As you remember from the definition of chronic viral infection, في وقتها عرفنا الفيرال chronic infection وقلنا اكو نوعين من الكرونيك viral infection، اكو persistent infection واكو chronic active infection. فالpersistent infection means that the virus remain replicated inside the body with a certain level, and during whole period of replication the patient is infected for another children. Spread of the virus to other parts in the body may occur. Viral messenger RNA transcription, genomic RNA synthesis, and nucleocapsid formation occur in large cytoplasmic inclusion bodies to avoid recognition by the host immune response. Most progeny virions remain associated with the infected cell surface. A fusion of infected cells with the adjacent cells result in the formation of large multinucleated giant cells calling syncytia that undergone apoptosis. And apoptosis means the programmed cell death. Actually, the formation of syncytia is one of the ways that follow by the virus to escape immune response. Because it permits the transmission of the virus from one cell to another without being outside the cell, without being in the extracellular environment, because the extracellular environment is rich in an antibody that may neutralize and inactivate the virus. Desquamated epithelial cells form the plaque that with mucus and fibrin may cause lower airway obstruction. Pathogenetic mechanism of severe respiratory syncytial virus disease likely involve both the extent of viral replication and the host immune response. It is possibly that an immediate hypersensitivity to virus IgA interaction may be involved, because as you know, the IgE antibody is attached to the mast cell, leading to liberation of what we call it vasoactive materials like serotonin, kinin, and histamine, which act to liberate fluid from inside the cell to the outside, and by this it act to narrowing the air. Clinical findings: the spectrum of respiratory illness range from common cold, which is very mild condition, in adult through febrile bronchitis in infants and older children, and pneumonia in infants, to bronchiolitis in very young babies. Febrile bronchitis means bronchitis associated with fever. In 25 to 40% of respiratory syncytial virus infections, the lower respiratory tract is involved. Progression of symptoms may be very rapid, leading to death, and as you know, the lower respiratory tract infection are very dangerous, frequently leading to death. The mortality rate in normal infants is low, about 1%, but if the respiratory syncytial virus infection is superimposed on pre-existing disease, for example, congenital heart disease, the mortality rate is high, up to 35%. Respiratory syncytial virus is an important etiological agent of otitis media, since about 33% of children with respiratory syncytial virus develop otitis media, of course, through the Eustachian tube. Reinfection is common in children and adults, and here is the question: why reinfection is common? Immunity: a high level of maternal neutralizing antibody present during the first 2 months of life and are important as a protective immunity. So severe respiratory syncytial virus infection begins in infants at 2 to 4 months when maternal antibody levels are falling down. Respiratory syncytial virus is not an effective interferon inducer like influenza and parainfluenza. The role of the immune response in viral infection is controversial. However, secretory IgA may protect against reinfection, and that cell-mediated immunity is important in recovery of the virus from the body, because they act to destroy the virally infected cells. Laboratory diagnosis: respiratory syncytial virus differ from other paramyxoviruses by lacking hemagglutinins, so hemagglutination and hemagglutination absorption assays are useless. First, isolation identification of the virus or detection of the viral antigen in respiratory secretion is the procedure of choice. Second, detection of viral nucleic acid in respiratory secretion by PCR. Third, serology. Serum antibodies can be assayed by complement fixation, neutralization, and ELISA techniques, which are also important for epidemiological studies. As we know, the ELISA technique can detect antibody and antigen, but here the serum antibody only mentioned. Epidemiology: respiratory syncytial virus is distributed worldwide and recognized as the major pediatric respiratory pathogen. It is the most common cause of pneumonia in children less than 5 years. It also can cause pneumonia in elderly and immunocompromised patients. And actually, these three categories: children below 5 years, elderly, and immunocompromised patients, forming the highly risk group for lower respiratory tract infection. Respiratory syncytial virus can be isolated from 40% of infants less than 6 months with bronchiolitis and from 25% with pneumonitis, but never isolated from healthy infants. Reinfection is common, although the presence of specific antibody, and here is the question: why reinfection is common? Intrafamiliar spread among sibling and adult is common, especially among Iraqi families. We have extended families, and this phenomena is very common. Respiratory syncytial virus spread extensively in children each year during winter season and rainy season. As you know, these seasons are associated with change in the environmental temperature, which may act as cofactors or risk factor for infection. The antiviral ribavirin administered in aerosol for 3 to 6 days has clinical benefit for hospitalized infants. There is no vaccine for